Thank you for the invitation. It's nice to be back in the city where I first learned about medicine. I went to Cornell when it was still called Cornell. And tonight, I'm going to talk about something that you all probably have a less experience with than you do with GYN cytology, since it's relatively new. But it's something that I'm pretty passionate about, and I've spent a lot of my professional career working on. For some disclosures, FIVAX and Antiva are companies that are working on therapeutic HPV vaccines. And Roche and Hologic, you probably know from the GYN cervical cancer screening world. What I'd like to do in the next 45 minutes or so, and I'll probably end up talking fast because there's so much I want to tell you, is talk a little bit about why we should even think about anal cancer and potentially screen for this disease when it's a rare disease. So who are the patients or the people, the populations most at risk? And then I'll spend the better half of it talking about how we could potentially screen for HPV-associated disease of the anal canal using the model that we've borrowed from cervical cancer prevention with cytology, colposcopy, which is in the anus we call high-resolution anoscopy, and then targeted biopsies. So as I said, cervical cancer is rare. It's only about 1.8 per 100,000 women, a little bit more common in women than men in the general population. But it's increasing in incidence. It happens about 10 years, occurs about 10 years later than we see cervical cancer in women. But it is, again, increasing in incidence quite dramatically. In the last 5 years, the perspective for 2017 from the American Cancer Society is over, about 8,200 cases. That's gone up over 2,000 cases, or almost 2,000 cases in 5 years. And we're seeing increases in both sexes, both men and in women. In part, if you look at the bottom, those are years of birth, so it's the birth cohort. So it's the baby boomers and on who are contributing to this dramatic increase in anal cancer incidence. And that's in part because of the changes in sexual practices with the Summer of Love in the 1960s, as well as the HIV epidemic and the fact that HIV now is not a life-limiting illness, it's a chronic illness. So HPV has the time to wreak its havoc with persistent viral infections. Let me put it in perspective a little bit more because I think the numbers are telling. Prior to screening for cervical cancer in the United States, the incidence of cervical cancer was about 40 to 50 per 100,000 women. Again, we've done a great job. We haven't done a perfect job, but now the estimates are about 7.5 per 100,000 women. How about anal cancer? We already looked at that number. In women, it's rare. So is this a public health problem that deserves a screening program? Probably not the general population of women. But if you look at estimates of men who have sex with men, gay men, prior to the HIV epidemic, it was 35 per 100,000, or excuse me, 100,000. That's almost what cervical cancer was in the general population of women. If you look in HIV positive MSMs, the estimates are 3 times that. Incredible. That's higher than the cervical cancer rates pretty much anywhere in the world, their rates of anal cancer. And HIV positive women also have high rates of anal cancer, similar to the HIV negative gay men. So maybe we should think about targeted screening. And primarily, these are the main targets, are people with HIV disease, both men and women, and gay bisexual men who do not have HIV. As we think about other populations, and I'm only going to talk about this briefly, the women who do get anal cancer in the general population are primarily women who've had problems with HPV disease elsewhere in the genital tract. So they and their HPV do bad things together. Women who've had high-grade cervical disease, women who've had high-grade and particularly high-grade vulvar disease, vulvar cancer, often have anal disease as well. Other groups to think about, if resources are available for screening, are patients who are immunosuppressed for other reasons, and have normal life expectancies or longer life expectancies, particularly the solid organ transplant folks. We know kidney transplant folks are at definitely increased risk of anal cancer. In general, when you're starting to think about this, starting to screen maybe at the age of 40 in people who have intact immune systems, again, because we don't see the cancers until about age 60. And though if they're immunosuppressed, we're seeing patients develop their cancers about a decade earlier. So start then. As part of the ASCP, we put out a white paper of some thoughts of the current state of screening for anal cancer in women. And again, as I'll mention coming up, there are no national guidelines for screening for anal cancer. But in areas, particularly in places like New York City, which have the ability to screen and treat these patients, we might start targeting particularly women with HIV disease, women who've had high-grade vulvar disease, high-grade cervical disease, or cancer. These diseases are remarkably similar. There are significant differences, but they're both sexually transmitted, transmission of the high-risk HPVs, and in particular, HPV-16 is, the bad guy. It is as prominent in the anal cancer as it is in the other area of focus now for HPV cancers in the oral pharynx. It causes the majority of cancers in the anus as well. The other thing that both the cervix and the anus have is a transformation zone. It's where two different epithelial cell types meet. So in the cervix, it's the columnar cells of the endocervical canal with the squamous cells of the exocervix. In the anus, of course, it's the distal rectum, and then the squamous-lined anal rest of the remainder of the anal canal. And the lesions the precursors to cancer and the infections look remarkably similar on both cytology and histology. And the cancers we're talking about are squamous cancers. As far as I know, there is not an equivalent of an HPV-associated glandular cancer in the anus. There's still lots of problems with coding of cancers, and a lot of the anal cancers that are coded as adenocarcinomas are actually low-lying rectal, run-of-the-mill colon cancers in the anus. And a lot of the rectal cancers that are coded as squamous cancers are HPV-associated cancers of the anal canal. Briefly, anatomy. For those of you who haven't thought about anal canal anatomy in recent times, we're talking about the surgical anal canal, which is the area of the anal canal that's opposed by the tension of the internal and external anal sphincters. The anatomic anal canal is distal to that from the dentate line down. But a lot of the good stuff, or the important stuff, is happening in the transition zone or transformation zone, which is proximal to the dentate line and variable lengths going up into the distal rectum. And again, when you look at these under the microscope, they're the same lesions. If I didn't have the little label cervix and anus, it may be difficult to say, oh, that's endocervical epithelium or that's colonic epithelium in the anal transformation zones. So both the infections and the precancers are remarkably similar. So with that, we can use what we know about cervical cancer prevention to use similar screening and diagnostic tools. Now, as we all know, the world of cervical cancer prevention is dramatically changing, with HPV going to the forefront, with molecular diagnoses going to the forefront for primary screening. Some issues with that I'll talk about as we go along when we talk about anal cancer screening. But it's an imperative. If you start screening for the disease, you need to have the mechanisms in place to deal with an abnormal screen. And I get, consults like, okay, here's this anal cytology and it's a high grade, and then they go, well, what do we do with that? Because they don't have the clinical colleagues who are trained to be able to evaluate those patients. So that's an imperative. There are no national screening guidelines for anal cancer. Both the American Cancer Society and the Centers for Disease Control say that, yeah, there's experts out there who say that we should probably consider doing this. Some of the societies, including the New York State Department of Public Health, their HIV Institute, says, yes, definitely screen, but that's still a rarity. The surgeons, the colorectal surgeons are getting on board, and we're doing another training course for the colorectal surgeons coming up. The AIDS doctors are getting on board because they're seeing their patients get this disease. A nice break slide. Anal cytology can be very pretty, just so you know, and poop can be very pretty. This is some plant material from an anal cytology. So when we're screening, if we follow that cervical model, the older cervical model, we screen with cytology first, and then for the abnormal screens, go on to colposcopy, high-resolution anoscopy with targeted biopsy. One of the things that's also an imperative, if you're doing anal cancer screening, is to do the digital anal rectal exam. We like to say dare to dare, because this actually is the cancer screening test. Cytology is more the screening test for the intraepithelial lesions, but it's the finger that can palpate areas of induration, hardness, nodularity, areas that you touch and the patient goes, that hurts. That's an indication of an area that needs to be evaluated. So that we can, all our clinical colleagues, every clinician can do that, even without having the rest of the mechanisms, because we have mechanisms in place to treat anal cancer. It's more of the evaluating and treating the intraepithelial lesions. That's the problem. So I started doing anal cytology back in the 80s. I guess that dates me a bit. And it was first incorporated into the Bethesda system in large part because of Diane Solomon invited me to the 2001 conference. But also coming from New York, I'm sure you all have had many stories about Dr. Koss. And after I presented my little blurb at the meeting, Dr. Koss came up to the microphone and he said, "Stay out of the anus." Nonetheless, he asked me to write a chapter, which I wasn't able to do, for one of his newer books after that. So I think he might have had a little bit of a change of thought. But it's recommended that we use the same words that we use for GYN cytology in the anus. It's the same disease process. So low-grade, high-grade SIL. We also have the wannabes, ASCUS and ASCH. And again, one of the things that Bethesda did was give us GYN cytology guidelines for specimen adequacy. And we have that for the anus as well. I think if the group is primarily cytologists, one of the hardest things when you start seeing these specimens is working with your clinical colleagues to get adequate specimens. It takes, when I've trained my GYN residents how to take anal cytology. I say you go in further than you think you want to go. You put more pressure trying to unfold all those folds of the anal canal that are opposed at rest, and you take more time than you think you want to, because you're in this organ that no one wants to pay any attention to. So the method that we've used, developed at UCSF, Joel Pileski, who's the infectious disease doc, who's sort of the king of anal cancer screening, is we've developed this test using just a synthetic fiber swab. This is our great swab. You know, it's nothing fancy. Do not use a pre-quart swab. You don't need all those little fancy, very expensive collecting devices, but you need your clinicians to work. And truly, as Dr. Lehman said, you know, it's the experience of the clinician will get you the good sample, not necessarily the device. But the goal is to sample the entire anal canal, okay? And not just that anatomic anal canal, the whole surgical anal canal. So you basically go in, you put your swab in until it butts the wall of the rectum. And then you start collecting your sample. You collect from the transition zone, the transformation zone, which has squamous metaplasia. So you'll see squamous metaplastic cells. Then as you go distally, it's a non-keratinized squamous epithelium. And as you get out towards the verge, it's a keratinized squamous mucosa. So you can see all those components. For Bethesda, we sort of arbitrarily defined that you need to have at least 2,000 to 3,000 nucleated squamous cells, as opposed to, say, the 5,000 on liquid-based cytology for the cervix. For thin prep cytology, that's about 1 to 2 nucleated squamous cells per high power field. For SurePath, 3 to 6 nucleated squamous cells. And again, you want the nucleated squamous cells. But you'll find, if your clinicians are experienced at this, that the cellularity is almost, it's like a GYN pap. You can usually tell the difference because you'll have more anucleate squames and maybe more fecal material. The background flora will be different, but they're cellular. You look at them grossly and they're just as cellular as a cervical cytology. And again, all of those normal components you'd expect to see: columnar cells from the distal rectum, nucleated squamous cells, squamous metaplastic cells, and the anucleate squames. In my experience, you don't see as prominent reparative changes on anal cytology, although you clearly see a lot of reactive changes, maybe with tight perinuclear halos, a little bit of nuclear enlargement, but not as much of that true syncytial sheet-like finger appearance of reactive reparative changes. Organisms, I love bugs. You can see bugs, the same kind of bugs you see on cervical cytology. Again, most of us in this room would be able to easily identify herpes and Candida. But you also sometimes see bugs that are a little less common on GYN cytology. Some of them are organisms that reside in the anus distal rectum. Some of them are just passing through. Some may be causing disease. Some may not be causing disease. So here we have amoeba, pinworm eggs, and the last are strongyloides. And that was actually from quite a while ago from a patient who had fulminant AIDS and was dying of disseminated strongyloidiasis. For amoeba, that's probably the thing that you will see the most. And I did not do laboratory medicine. I'm not a microbiologist. I'm not good at I do not speciate the amoeba. I say they're present. Essentially, if the patient has GI symptoms, then my clinicians will do more of that workup and send it to the right person who actually knows how to look at like the CDC diagram and match up what they're seeing. Clearly the big guys are, the histolytica, And Entamoeba coli, you'll very easily recognize that some are big and some are much smaller. You can see both the cyst and the trope forms. And I play and I always try and match them up, but I don't put it in my report. But what we're really looking for, of course, in anal cytology is looking for HPV-associated disease, the infections and the precancers. We can also see cancer, unfortunately, and my experience getting to be too often that I'm diagnosing it on anal cytology. For glandular abnormalities, again, I mentioned we don't have that counterpart of an HPV-associated glandular cancer in the anus. So you do not see that spectrum of endocervical abnormalities. But I have seen I have seen rectal adenocarcinomas that were sampled with anal cytology. I've seen different polyps. We've had patients, I had something I called an atypical glandular cell, and they've ended up being hyperplastic polyps or adenomatous polyps, again, from the colon. We also have a couple of unfortunate patients who have Paget's disease that's extended into the anal canal, and seen that on anal cytology. But when you look at these, we're all saying that's perfect. We can, we know it. Those are classic low-grade SIL cells. Some with more pronounced HPV cytopathic effect than others, but still very recognizable. Sometimes you'll get more degenerative changes in the bottom right. You're essentially seeing what I call, HPV ghosts. The nucleus has degenerated completely, and you just see this perfect halo. It has all the nice irregular rim, both in the center and the outside. Binucleation, multinucleation, those nuclear changes, the big, bad, and ugly nuclei that we are all familiar with the dysplastic changes. So just like for the cervix, the low-grade lesions can be caused by both low-risk and high-risk HPV types. They're the productive HPV infection. And in general, if these are not symptomatic, we do not treat them. In our population, you can have big bulky warts, and a lot of times they are symptomatic, so that we do treat them on occasion. The high-grade lesions, again, classic high-grade. Big, bad, ugly nuclei, very little cytoplasm. That's the very simple way. Technology. In the upper right, high-grade lesion in squamous metaplasia, where you'd expect to find high-grade transforming infections in the transformation zone. The other thing you will find in the patients who are being screened is they often have a lot of disease, and they have a lot of low-grade and high-grade disease. So you'll see on the bottom right, patients who have both low-grade and high-grade on the same cytologic specimen. Again, bottom right here, you'll get more keratinizing lesions than you see on GYN cytology, because they're all contiguous. The transformation zone is contiguous in a very short distance with a non-keratinized squamous epithelium to a keratinized epithelium. And these lesions can span across those zones very quickly, which is one of the reasons why some of the classification of these lesions is so challenging. Is it rectum? Is it anal canal? Is it perianus? It can involve all of those areas. But squamous metaplastic cells, again, constant, and it works great with both of the liquid-based cytologies, both ThinPrep and SurePath. Most of the images that I'm showing you are ThinPrep, because that's what we use at UCSF, but there's a SurePath one. And they also work on conventionals, but they're not nearly as fun. I'll talk about that briefly. And of course, the high-grade lesions in the anal canal, just like the cervix, are caused by the high-risk HPV types, particularly HPV 16. Most of these will persist or progress over time. We do not know all the answers to that. And there's some evidence that some of the high-grade lesions have a higher regression rate in the anus than they do in the cervix. That's primarily from the work from the Australian groups. But of course, HPV, when it makes its mistake and persists and ends its productive life cycle, it can make another mistake and integrate into our own host cell genome. And that's when things really start getting bad, because you get even more overproduction of the oncogenic E6 and E7 proteins, which cause all the genetic changes in our cells, which eventually lead to malignant transformation. And this, of course, is what you don't want to see. So the cancers, they can be keratinizing squames, they can be non-keratinizing squames, they can be combinations thereof. The challenge, diathesis, I find a tumor diathesis difficult to say, oh yeah, that's a tumor diathesis, in part because you're dealing with a fecal material, and so the particulate, you don't get to know that that's definitely proteinaceous debris caused by an invading cancer. You go, maybe that's just, fecal material. But when you start getting a combination on liquid cytology, you still get that clinging type of diathesis that can help. And of course, the cellular characteristics can also help you make that diagnosis. So the treatment for anal cancer is a tough treatment. It's combined modality therapy, radiation, and chemotherapy. The pendulum went from years ago in the 70s, it used to be abdominal perineal resection. Scoop out everything in the pelvis, close up the anus, the patient has a pouch. They found out that radiation and then radiation and chemo were just as effective, actually even more effective than APR, than primary surgical treatment, but at a cost. It's really tough on our patients. They have enormous amount of symptoms, and some of the time, they actually have to have the colon placed at rest, and they end up with a colostomy to just at least while they're recovering from the process. So, and anal cancer staging is staged that the T1s are 2 centimeters or less. Those are pretty big tumors, and that's the treatment for those is still a combined modality therapy. So I'll tell you a little bit about a change where we may be able to have the pendulum swing back and do conservative excisional therapy on these very early cancers that we're now finding because we're screening. And then if the patient fails that primary conservative surgical therapy, then they have the chemoradiation as their second line, and then the third line being the abdominal perineal resection. But we also have times when we can't tell what it is on cytology. We get suggestions that we have an infection or suggestions we have a precancer. Ask us an ASCH. ASCH is often in metaplastic cells, just like it is for cervical cytology. But again, you oftentimes get some of this keratinizing epithelium, sort of atypical parakeratosis that can be really hard to classify, either as a true lesion or not. Some of the older studies that we did at UCSF using conventional smear cytology, we started out before the liquid-based cytology really took off, showed that the sensitivity and specificity was similar to cervical cytology. Again, there's a wide range in the literature, and some of it depends on how good of a sample that we as cytologists receive to be able to evaluate. And in the CAP glass slide programs that go around and around, it's sort of disappointing in the first, this was from our first 5 years or so experience, hitting the target diagnosis only about 55–60% of the time for high-grade lesions and cancers. So it's your challenge as you begin to look at these to consider them very similar to GYN cytology, and we're really good at high-grade lesions on GYN cytology, so we should be good at them on anal cytology as well. So keep plugging away at it. But things are changing, and we're getting new tools available for HPV disease prevention, screening, and prevention. Of the morphologic techniques, the dual stain with P16 and Ki67 will probably get to the US very soon. It's CE marked for the cervix in Europe, and that can be, it's much more objective to look at a red and brown stain and say, yeah, there's a red nucleus and a brown cytoplasm, than to say, okay, is this a dysplastic nucleus? Does it have enough features? Or is it just reactive change? Or is it something I don't know really what it is and I don't want to see it again? Those kinds of things. So what our newer techniques are helping with our art of interpretation, which will always remain an art and always have more inter-observer variation and fallibility, when something like dual staining tends to be more of an objective interpretation. And that leads me to the other big challenge in HPV disease is the use of HPV testing. So first off, there's none of the 4 FDA-approved tests are approved for the anus. They work. Your laboratory has to basically validate it on that specific sample. In my mind and in our practice at UCSF, and I didn't get into all this epidemiologic data, but HPV in those target risk groups, people with HIV disease, men who have sex with men, have very high rates of anal HPV. So just for instance, in our study groups, HIV positive MSM, 90% have high risk HPV. HIV negative MSM, 75% have high risk HPV. So does it work as a screening test or as a triage test for the minimally abnormal cytology? Maybe not. I mean, its beauty and its use in cervical cytology is because that HPV prevalence in your population is lower. What we do use it for is in the post-HRA and the post-treatment management of patients, which we also use it for in the GYN world, although, again, the tests aren't approved for those indications, but we all use it for like the post-colposcopy test of cure or following patients longer term. So it's good for post-colposcopy or post-HRA treatment and management. We clearly use it in our post-cancer treatment patients to see. That said, as we get more and more of our HPV tests that allow for genotyping, targeting patients that are HPV 16 positive may play a very important role, particularly in places that don't have the infrastructure to do quality cytology like here. And there's lots of places that don't have quality cytology, and it's hard to develop it. So the genotyping may play a role. We know that if the HPV test is negative, that negative predictive value is exquisite. It's very good, just as good as it is in the cervix. Of course, no test is perfect. The problem is in the populations we're targeting, we expect to see fewer and fewer patients who are HPV negative. Another group that you might see it be much more commonly used is in a patient who had incidental warts or high-grade lesions found on colonoscopy. So HIV negative patients, 60-year-old women and men who they retrograde, look, and they see something in the anus and they take a biopsy of it. So the HPV testing there may be better. But again, that's not really that screening population anymore. So the way we triage patients is essentially anyone with an abnormal cytology goes on to high resolution endoscopy. Now that is because we are fortunate enough and also have enough patients, enough clinicians trained to do high resolution endoscopy. In a lot of areas that are starting to look at this, they may not have that luxury. And instead of having a backload of 6 to 8 months of patients who have an ASCS, they'll focus primarily on the ASCH and the high SIL patients and take them first to high resolution endoscopy. Again, the management algorithm is fairly similar to what we do with the cervix. When you find high-grade disease, I'll put a caveat on that, but we'd like to treat the precursor lesions to reduce the risk of cancer. But again, we don't quite know if that works yet. Some more plant material. So what do you do if if the patient is triaged to HRA? In colposcopy, just like a cervical colpo, I like to call it, you look for things A, B, C, and V. You look for things that turn white with vinegar. I always use the term vinegar with my patients rather than acetic acid. It sounds so scary. I'm going to put some acid on you. And then it burns, right? So vinegar, and they had vinegar on their salad at lunch. They tolerated that quite well. Okay, so acetowhite lesions, A's, borders of the lesions. Are they distinct from the rest of the epithelium, particularly the squamous border? Contour changes. We all know warts can be warty. Are there the cerebriform or the papillary microspiculated? Contour changes, more common in low-grade lesions than in high-grade lesions. And then colposcopic vascular lesions. We talk about punctate or mosaic patterns, and I'll show you those. So this patient, the HRA, you can see something that really looks like a wart. It's a big sort of cerebriform, lumpy, condylomatous-looking wart. And that patient had a wart on histology and a wart on cytology, all low-grade lesions. The high-grade lesions here, colposcopically on that HRA, you're seeing, this is actually a fairly large lesion. And you see that the vascular changes here, it's white with the vinegar, and the vascular changes of punctate up in the top. You see the little dots looking at you. Those are vessels that are coming out at you that you can visualize. And then the mosaic pattern sort of looks like, bathroom tile or chicken wire, blocks. And those are capillary loops that are just under the epithelium that you can visualize. More prominent with high-grade lesions, particularly what we call coarse punctation or coarse mosaic, which means that the distance between the capillaries varies. It's not necessarily the caliber of the capillary itself, but the distance, the size is different. And again, another high-grade lesion on cytology and histology. The cancers here on the HRA, that one has an ulcer, but you can see it looks like it sort of pops out under the edge of that anoscope. It's rigid, it's hard, your finger would palpate that. And then a tumor giant cell on cytology and a nicely or frankly invasive cancer there on the biopsy. So I mentioned that pendulum swinging, away from surgery to chemo and radiation. And now the pendulum has swung a little bit to conservative surgical management of these very early cancers, the superficially invasive squamous cancers that we're diagnosing in patients who are being screened. With the last project, the terminology that was coined for all of these early lesions is a superficially invasive squamous cell carcinoma. The definition of that for the anus is, again, arbitrary, given that we had no data, but it was an effort to get that data prospectively collected to start talking with our clinical colleagues and our pathology colleagues that we document these kinds of things. So maybe patients can be spared chemoradiation and treated initially by or only by surgical therapy alone. So we have quite a few unknowns left in this field. We do not know the progression rate of high-grade disease of the anus to cancer. We do not clearly know that treating high-grade disease of the anus will reduce anal cancer progression. And so we don't really know if treatment is effective. And that's in part because we're treating patients many of them, whose immune systems already are compromised. And they have their HPV and they'll keep their HPV. And they often have big lesions, multifocal lesions, circumferential lesions. And rather than, doing a leap on the cervix and taking out that whole transformation zone, you can't do that in one setting easily for the anus because they can heal with stenosis, and then you're causing even more problems. Some of the estimates, again, we're just getting estimates now. The Matchelek group in Australia are doing a prospective study where they're not treating patients. They've seen a higher rate of regression of high-grade lesions than we've seen in our group in San Francisco. But the progression seems to be less because we know that so many of these gay men and patients with HIV disease have high-grade lesions. 30% of them basically have high-grade lesions, but we're only at the very tip of the iceberg for anal cancer as patients get older. So we now, of course, are in the era of evidence-based medicine, and the bar is set very high to be able to say we should have national screening programs for anal cancer. There's never been a randomized controlled trial even for the Pap test, right? Never a randomized controlled trial. We know from epidemiologic data that it works, but now that's the bar that's set. So, and we're in New York, so I'll talk about the Anchor study. There's some folks who are involved with Anchor here. There's 3 sites in New York, what I call Cornell, which now has many other names like Presbyterian involved, at Montefiore, and then at the Laser Surgery Center down in the village with Steve Goldstone, who is a colorectal surgeon. But there's 15 sites in the United States. The goal is to screen about 17,000 men and women with HIV disease to find about a third of them, we expect, walking in the door will have high-grade anal disease on biopsy. And then they're randomized to one of 2 arms, either treating their high-grade disease or very close follow-up, because this study has grown out of a group or groups that think that we should be treating anal high-grade disease to reduce risk of progression to cancer. So they're going to be followed at least 6-month intervals or shorter, depending on what their endoscopy looks like, and followed for at least 5 years in the study. And hopefully we will truly answer the question, does treatment of anal high-grade disease change its natural history? Do we reduce the numbers of patients who develop anal cancer by treating these precursor lesions? And therefore, as an analogy, should we be screening for the precursor lesions in these high-risk populations? So we have good news and bad news. Good news is the incidence of anal high-grade and I'm sorry, that's the lemons. Those are bad news. We got a lot of disease in our high-risk populations. Treating our patients with HIV disease is a great thing with highly active antiretrovirals, but it does not seem to have much impact on HPV disease, okay? They still persist with the cockroach of the viral world. And evidence is mounting that we're going to continue to see more and more cancer, particularly in these high-risk populations. The good news, the best news is we now have incredibly effective vaccines that should be used for all of our next generations, girls and boys, to protect against HPV-associated disease. Incredibly effective. The 9-valent vaccine is, an incredibly powerful tool. The bivalent and the quadrivalent, again, all target HPV-16. That's the virus we want to stamp out for anal cancer, cervical cancer, vulvar cancer, head and neck, oropharyngeal cancer, period. For those of us who've already been exposed to HPV during our sexual lives, we have some of our tools to make a difference. To use the digital anal rectal exam, to use cytology, HPV testing, dual staining, all of these new tools that we'll have in the 21st century to make a difference and treating potentially and hopefully successfully treating high-grade disease. Therapeutic vaccines were still a ways away. This is an incredible indication for therapeutic vaccines because the anal canal is much harder to treat than the cervix. And thank you.
Thank you, Dr. Darragh. This is very informative lecture, very helpful. And we're going to take some questions from the audience. And who has some? Please.
You're all stunned. Or I was so good, there's no questions.
I always wondered about the adequacy for anal cytopathology and liquid-based cytology.
Yeah.
Where does the number 2,000 to 3,000 came from, and why it's a range?
It's clearly arbitrary.
Yes.
So there's been no real good studies. There was one study, Aaron did one on SurePath, and found that if you had 6 nucleated squames per high power field, which is double, that they found more lesions, or they had more abnormalities. It's clearly arbitrary. I was on the Squamous Adequacy 2001 group, and they turned to me and goes, "Well, what do you think?" And I said, "Well, you should, I see over 3,000 anal cytos a year." And notice that I call them anal cytologies rather than anal paths. And in part, that was because insurance companies wouldn't reimburse for an anal pap on a man because they don't need a pap, right? So I call them anal cytology. Arbitrary. Next generation folks, people who need to do studies and want to do studies, that would be an excellent one. I think it would be a challenging one to do to find out what is a truly adequate sample. To be honest with you, I think a lot of the stuff for GYN cytology is also based on expert opinion. I know the liquid-based manufacturers had to do a lot of stuff where they actually counted cells, but the adequacy, it's stuff where I'm still seeing disease on an anal cytology, 1 to 2 nucleated per squamous per high power field. Clearly, the majority of the samples that I see from well-trained clinicians, the cellularity is similar to a GYN cytology using liquid-based cytology. Yeah. Next question.
Do you know if current molecular, the HPV typing allows for the differentiation of episomal HPV versus the integrated HPV right now?
Not on the commercially available test. We can do that on a more sophisticated testing platforms, but not on the test that we use clinically. Yeah. Mm-hmm.
2 comments. Number 1, you didn't comment on the glandular cells.
Okay.
In terms of adequacy. Second one, we see quite a lot of mixed infection. Right? If you look at the cervical HPV, usually 16 dominant, 18 dominant, And on anals, we see the most, about 60 to 70% of actually mixed.
Yep. Again, in the high-risk populations, they're going to have multiple multiple HPV infections.
So why is that you have more other type? We use both
Mhm.
platforms. So why we see more other type in the anal than in cervical?
It's in part probably because of the populations that you're studying. So in the anal canal, the high-risk populations often have multiple HPV types, both low-risk and high-risk types. Interestingly enough, the HPV pattern is very different in men and women from some of the research. So you know the graph of HPV prevalence goes up in young women soon after their sexual debut, goes down, and then to a baseline that hangs out, still there, and then maybe another little bump, depending on what country you're in, for the menopausal, when our immune system sort of wane. In men, HPV prevalence is pretty much across the lifespan. So for both penile and anal studies, they get it and they keep it up there. Whether that is recurrent infections, new infections, not clearing their initial infections, I do not know the answer to that. Glandular lesions or glandular cells as far as adequacy goes, we report transformation zone components just like we do on a GYN. As you know, for cervical cytology, some of the work out of British Columbia showed that it's not either prospectively or cross-sectionally make that much difference of whether we as cytologists identify T-zone on a path. What I keep battling with my cytotechnologists is, remember, metaplastic cells are part of T-zone, right? They count. It's not just glandular cells. Interestingly enough, Jenny Roberts from the Australia group published last year, I think it was last year, maybe we're still just in February, an interesting study from their group showing that it was really the squamous metaplastic cells that had their presence at a much higher correlation with having abnormalities and biopsy-proven abnormalities. So similar to what you think, if you go really far in and you just collect there, you're going to have distal rectal cells, but not if you don't get into those folds where the transformation zone, the valves and crypts. So that's where the metaplasia is. That's where a lot of the disease starts.
Actually, major issues, they don't go far enough.
Yep.
They're always collecting, on the superficial one.
Right.
So that's why I think glandular cells is very important, especially for those who is not trained well.
Yes.
To do the smear, because that's a good indicator.
So that's another plea as you go in, and if you have the ability to have your clinical colleagues come down and look across a microscope with you, say, look at this, you got all poop. Or you got all nucleated squamous cells. So, you sampled really hard right near the verge, but that's not where we want you to sample. Yeah. Barbara Winkler, she's a New York pathologist. Many of you know Barbara Winkler. So we did a lot. We've written several papers together, and the paper we published, it's in an Australian journal, so it's not as easy to get a hold of. But we talked about Sexual Health is the journal, the whole journal on anal stuff. Talked about what makes anal cytology adequate, and what were the problems. Like if you had all poop, what could be remedied? What did your clinician need to do? Put more pressure on the lateral walls. If you had all anucleate squamous, things to help rectify and get better samples, because the cytology is only as good as the sample. We cannot interpret poop. I mean, poop in, poop out. If you get something good, you get something good. Yeah. Let's go.
So I have one way to comment. We just looked at a complete study on HPV genotyping on anal cytology. We were lucky enough to have co-testing done on most of our anal pap. We found that HPV 16 is high risk, but if they combine with Other type of HPV, like called multiple infection,
Uh-huh.
the highest risk of outcome or historical outcome to have high grade lesion. So multiple infection actually is a significant risk
Interesting.
factor
Very good.
for patients who have ascus and low grade.
And is this one of your presentations at SCAP?
Yes.
Okay.
And the other study they want to complete is to look at over 1,000 cases of anal pap, adequate specimen compared where they have granular cell and non-granular cell, presence of granular cell component, and we didn't find any significant difference.
Yeah, in that study I quoted earlier on, those were patients, all research patients who had HPV testing, anal cytology, HRA, and biopsies of lesions.
Yeah.
And we didn't find that it made a difference. That's why I mentioned the Jenny Roberts study showing that when they look specifically at metaplastic cells as part of T-zone component, it made a difference.
That may be interesting to go back and look at what type of granular cells are
Yeah.
actually present.
Yeah. What kind of T-zone is actually present? Yeah. Excellent. Thank you all very much.